Absolutely, delighted to. Can everybody
Right.
hear me okay?
Mhm.
Great. So welcome everyone. I'm so glad that you have been able to join us for our program this evening. This is the second event this fall in the collaboration between Ontario Tech and the Oshawa Public Libraries in our Beyond the Walls series, in which we bring some of the ideas and the research and the work we're doing to share with you and to get your feedback and to engage in discussions about how these issues impact our everyday lives. Before we get started with this evening's speaker, Stephen, I would like to open with a land acknowledgement. So we are thankful to be welcome on these lands in friendship. The lands we are situated on are covered by the Williams Treaties and are the traditional territory of the Mississaugas, a branch of the Greater Anishinaabe Nation, including Algonquin, Ojibwe, Odawa, and Potawatomi. These lands remain home to many Indigenous nations and peoples. We acknowledge this land out of respect for the Indigenous nations who have cared for Turtle Island, also called North America, from before the arrival of settler peoples until this day. Most importantly, we acknowledge that the history of these lands has been tainted by poor treatment and a lack of friendship with the First Nations who call them home. This history is something we are all affected by because we are all treaty people in Canada. We all have a shared history to reflect on, and each of us is affected by this history in different ways. Our past defines our present, but if we move forward as friends and allies, then it does not have to define our future. Our plan for this evening is to turn things over to Stephen for about 20 minutes, and then we have the rest of our time together for a Q&A where we can drag more information out of him and have him tell us more things. So without further ado, I am delighted to introduce my colleague, Dr. Stephen Hale.
All right, thank you very much, Andrea, and thank you everybody for coming. And I want to thank the Oshawa Public Library for helping to put together this fantastic series. I want to begin with a picture of an individual who I think is now familiar to most of us. So this is Dr. Theresa Tam, our chairman. She is helping us deal with the current crisis that we are experiencing with respect to COVID-19. She also chairs the Special Advisory Committee Epidemic of Opioid Overdose Crisis Committee team. My apologies. And the committee released some concerning data in September of this year. Data showing that for the first time in about 40 years, the life expectancy, which has been gradually going up, came to a halt, came to a stall. And so the numbers that they released showed that between January of 2016 and 2020, around 16 away from an apparent overdose death. And that number is about 1,018 just this year in January and March of 2020. So the numbers are continuing to go up, which is in the wrong direction, even though strategies are being implemented at the federal, provincial address to address this issue. So is this something that we can handle? Is this something that can be brought under control, mitigating harms and death associated with this crisis? And I think that it is. I think that like any epidemic, this is something that can be addressed, but we need to look abroad and we need to look to other countries and into the past to find some answers. And so I'm optimistic that this is something that we can do. And there's a couple because we've seen similar strategies employed in the past. And so one example is in the United Kingdom, going back to the 1980s. And so at this period of time, there was a new virus that individuals didn't know very much about at the time. It was AIDS. And in 1985, ending of HIV and the virus that leads to AIDS, the United Kingdom was noticing that there are people who were diagnosed with AIDS and dying from AIDS were relatively lower compared to other countries around the world. And so they had started to wonder if perhaps they were potentially going to avoid the epidemic that was affecting places everywhere else. And so a scientist by the name of John Robertson had decided to investigate and look a little bit more, because he had a sense that the best way to get an understanding of how serious the epidemic was to figure out rates of HIV diagnoses, something that would provide a better indication of where things might be heading in the future. And so he had tested some samples amongst two groups, an individual or a group of individuals who were attending a clinic in Glasgow, and then a group who had been using drugs. And what they found was that in Glasgow, the rate of HIV infection was 0%. Optimistic findings suggesting that perhaps indeed the UK was avoiding an epidemic or avoiding numbers that were seen in other parts of the world. And then they did the exact same test in Edinburgh and found that the rate was 50% in terms of the number of individuals diagnosed or testing positive for HIV. But this raised concern, a difference of 0% in Glasgow testing positive for HIV, and then 50% testing positive for HIV in Edinburgh. And so the concern that came from this was that there was the potential that this could then develop into a pandemic. And we're living through a pandemic where we took this seriously as well. Within months, they held an emergency meeting in the House of Commons. A few months after that, they decided to pilot 12 programs across the country, which were we refer to as needle exchange programs or syringe exchange programs, to attempt to prevent what could down the road. And so syringe exchange programs are places where individuals can obtain free sterile needles in exchange for returning their previously won exchange. And the reason why the government decided to pilot this was based on advice coming from the very doctor who had tested and generated the numbers in Glasgow and Edinburgh. What this doctor had concluded was that there was something very different going on in both of these cities. In Glasgow, where the rate of HIV infection among those who were using drugs, access to new sterile syringes. You could buy them at a low cost in pharmacies, and if police officers found you in possession, they didn't take them away. Whereas in Edinburgh, the exact opposite was the case. If police officers found you in possession of sterile syringes, then not only would they take them away, but you could potentially arrest. And in pharmacies, you couldn't get these syringes. And so it became fairly clear to the researchers here that the factor that was helping to keep rates, if non-existent, was easy access and low-cost access to sterile syringes. And so within 4 or 5 years after that, about £250,000 had been invested into establishing these needle exchange programs. When they found out that they were relatively successful and were not causing any increases in crime, they there were over 300 syringe exchange programs operating across the country, costing about £238 million. And at that point, the British government had declared that the crisis had been largely averted. And to this day, rates of HIV infection remain about 8 times lower in the UK than they do here. And they largely attribute it to this program. So this is one example. Another example of HIV infection in Europe. And roughly 1% of those in Portugal were struggling with opioid dependence of some form. It was a country where most people knew somebody who was impacted, and the Portuguese government decided to do something bold. They decided to decriminalize the possession of all drugs, and a possession of all drugs of up to about 10 days worth. About a year after that, and this graph is thanks to compliments to the Beckley Foundation, what we see is a very gradual but significant decline in the rate of HIV and AIDS among people who use drugs. But what was more striking than this was that we of opioid overdose deaths within 1 year after the decision to decriminalize drugs. And so the question is, what was the secret? Why is it that this strategy worked so well in Portugal? And I want to come back to that question in a bit, but for now, just that Canada, we're doing things that are working as well, but I think that there are lessons that we can learn from abroad to help us understand why they're that we're necessarily hoping for. And so one place that we can look is supervised consumption facilities. And so supervised consumption facilities are one example where I think the numbers don't lie with respect to the number of individuals and the number of lives who have been saved. And so why is that? Well, supervised injection or individual are places where individuals can bring drugs that have been illegally purchased in order to consume them under medical supervision with sterile needles that have been provided by this facility. So to be clear here, these are places where people bring drugs that have been illegally purchased. And so these are drugs where the extent to which they might be contaminated with fentanyl and other very dangerous substances are things that, unless there's facilities or technology at these places to allow for testing, it's often unknown. And so as a result of that, there are dangers associated with these, with the use of these drugs. And indeed, people do overdose at these facilities. In fact, in any given year, there's hundreds of individuals who will accidentally overdose consuming drugs. In numbers don't lie with respect to the effectiveness, is that although we see hundreds of overdoses taking place at consumption, we don't have a single case of an individual who has died as a result of an overdose. So since the first facility in site, not a single person has died. So the effects are quite striking with respect to the numbers, the thousands of individuals whose lives have been saved by attending these supervised consumption facilities. And so we've seen thousands of lives saved, but in terms of increasing number of overdose deaths, they don't appear to be bringing to open enough and establish enough supervised consumption facilities across the country. And so we need to remember the lesson that we learned from the United Kingdom. When faced with what was perceived to be an emergency crisis in the 1980s, the government acted quickly. They invested millions of pounds within a matter of months, and they opened hundreds of needle exchange programs within a few years. And my worry is that we did back in the 1980s. So while the UK, OP90 here in Canada, we had only opened about 35 similar programs. And so today, at present, we have 39 supervised consumption facilities operating across the country. And that number on the face of it might be graphically distributed, the vast majority of those 39 facilities are located in just a handful of provinces across Canada: Ontario, British Columbia, Alberta, Quebec. Saskatchewan's on the list, but there's only one consumption facility there. And it means that the entire Atlantic region of Canada doesn't have a single supervised consumption facility. And an area and region that I'm worried about the most is the Northern Territories, where again, there are no supervised currently. And also, we're talking about a region of the country with overdose death with respect to opioids. So we need to open more supervised consumption facilities in more parts of Canada. And when we do look at the provinces where we do have supervised consumption facilities, also largely concentrated in some of the largest cities in particular. So we have facilities in Toronto, for example, in Ontario, or in Montreal and Quebec, but then there's large that we know save hundreds of lives on a yearly basis. Oshawa is an example of a city that doesn't yet have a supervised consumption facility. And yet at the beginning of September, there was a period of 36 hours in which there were 11 calls for emergency services related to opioid overdoses, and one person, the mayor of Oshawa, Dan Carter, said that we need to do everything we possibly can to address this epidemic. And we have to remember that this was something that he had personally experienced when he saw somebody overdosing in a public parking garage about a year ago. And so he says that we need to do everything we can to address this crisis. Has to include the establishment of more supervised consumption facilities based on what we know in terms of its impact. And yes, we need multiple. A city like Oshawa needs more than one facility. Let's go back to Vancouver, Insight 2003. On any given day, outside of the facility, because there's only a certain number of spots within the facility for people to be safely consuming. So you have the people waiting on any given day, but of course, this has gotten worse as a result of the pandemic. With physical distancing and other measures, you can't have as many people inside of these facilities, which means more people outside waiting to get inside, trying to physically distance, waiting for long hours. And it's not that Vancouver doesn't have more facilities, they do, but in order to get to these other facilities, it would involve having to make quite a trek by transit, which can be very many of these facilities. Think about opening more facilities within these cities, recognizing that rural areas across Canada are particularly in need as well. And to look to countries abroad to think innovatively and creatively about where all the possible places can be that these facilities can open, establishing injection and community centers and prisons. That's a lesson that we learned particularly from operating supervised consumption facilities within prisons for almost a couple of decades. Difficulties with the sound. I feel like it's cutting in and out. Did anybody want me to stop for a second, or?
Hi, Stephen. It's Allison. Can you hear me?
Should I stop? Yep. Yes.
Yeah, you are cutting in and out for me, at least.
Yes, I can hear you. Are you having trouble hearing me?
You keep cutting in and out a bit.
I can hear you just. All right. I think, yeah, you're cutting. I think the sound's cutting in and out for me as well, unfortunately.
I was wondering, you mentioned about rural sites. Mm-hmm. Are you able to talk a little bit more about the rural, any rural sites?
in terms of any rural sites that are presently in operation, or the needs?
Do you, I guess more if you have any examples of any in rural locations?
In rural location, I mean, by and large, all of the facilities that are operating right now would be, I would classify them to be in more urban areas, more urban centers. So, so like we're looking at province like Ontario, where we see supervised consumption facilities would be Toronto, well, certainly, but St. Catharines, Kitchener, larger cities, but not areas that I would think of as being more rural. There's certainly a divide in which across all of our provinces we see is clearly larger urban cities, the larger urban centers, the larger cities, and the rural areas are largely being excluded, which again is particularly concerning, especially when we're getting in areas. Sudbury is an example. We do have some, northern examples of consumption facilities that have been operating for a while, but again, these are the cities. These aren't, and there are no locations in more rural areas. And we could say something similar for syringe exchange programs. Well, there are more, again, they're pretty. So does that help? Does that answer your question?
Yeah, that's, I sort of thought that they were mostly in urban areas,
Yeah.
but I was curious because you did mention that there was a need for them in rural, which is what I understand, is that there is this need. So, thank you.
There's a need for these facilities everywhere, in the same way that there's a need for syringe exchange programs everywhere. And again, a lesson that we can learn from the UK is that, with over 300 facilities operating across the country, they're in every area of the city. They're in rural parts of the country. They're in urban centers, but also smaller cities and towns as well, because of the extent to which they've been rolled out. How's the sound? Am I able to keep going or continue?
Hi, Stephen. This is Aziz.
Yep, go ahead. Yeah, absolutely, absolutely.
Like the voice on my side is a little bit choppy, but I'm not sure about the rest of the attendees. So
I saw go ahead. Jennifer said to please go ahead, but yeah, I want to make sure from the other attendees if it's okay to continue along. And I'll be happy if there's any other questions. I'll be happy to. I've got an individual asking, how do we overcome stigma within these neighborhoods? And that's an excellent question. And if it's okay, if I can hold off on answering that, that is something that I do want to touch on towards the end, because I think stigma, I agree, is such an important part of this, important part of the equation. This is a country where we see supervised consumption facilities operating within prisons as well. Again, areas where I see somebody saying that the voice is very choppy on their end. Apologies. I'll stop for a second and ask if to take a break. I know Carol's saying as well that it's choppy on their end.
Stephen, I think just continue and
yeah. All right.
Because you're in the middle of your presentation, just continue, please. Thank you.
Okay. All right. And another thing that's interesting and important to look at Switzerland is that on top of on top of establishing supervised consumption facilities within prisons, this is also a place where we saw advances with respect to not just supervised consumption, but also supervised consumption of heroin that is being provided to individuals who need it. And so another term for this, or a term that we've been using more and more and seeing more and more in the Canadian context, is this idea of safe supply or safer supply. Provision of heroin, which we would call diacetylmorphine. And diacetylmorphine is the scientific term or medical term for medical grade heroin. So in other words, heroin that has been by the government, that we know is pure in quality, that we know what its dosage is, and therefore can be prescribed or can be provided safely to individuals who need it. And so if we go to Switzerland, we see in the 1990s, in 1994 in particular, what was called the Swiss opiate trials. And so the Swiss opiate trials, which took place, involved two groups. One group of individuals, heroin, which we know is pure, doesn't have anything in it that's going to be dangerous, and that we know the dosage of, and so that we can control the dosage when it's being provided to somebody. And so 250 people received this medical grade heroin, whereas another group of 250 individuals received methadone, which opioid substitute, something that is part of the same family of substances, but is not the same as heroin, and therefore the effects can be receiving methadone instead of heroin. It can be helpful with respect to treatment. For others, it's not as helpful as they would like. And so they provided heroin to one group of 250 individuals, and they provided methadone to another group. And individuals, or the group that received heroin as opposed to methadone, experienced lower rates of crime and criminal recidivism, higher rates of employment, improved well-being. But on top of all of these things, the most striking findings was that among the group that received heroin and that were received heroin as part of these clinical trials, they experienced lower rates and less use of heroin over time in the group receiving heroin, who succeeded in being able to abstain long term compared to those who were receiving methadone. And so it's these results that put the provision of diacetylmorphine, including agonists and opioid antagonists, as well as cognitive therapy, residential treatment programs. The provision of diacetylmorphine is one of the most successful programs. And those that took part in the study and those that were behind the study argued that it was largely because there were relatively few controls in terms of how much heroin someone could receive. Or there wasn't any attempt to necessarily be prescribing less dosages. It was largely up to the individuals involved in the program. And so they argued that for the first time for many people, they felt relatively secure in their access to heroin. And this relative security led to increased emotional and mental well-being, access to heroin, less costly than it would be under other circumstances, and feeling in a more stable position and safe, moving towards using less heroin and moving towards abstinence. And so we've carried out a similar study here in Canada called NAOMI, which is an acronym for the North American Opioid Maintenance Initiative. So the only one of its kind in North America, and it's produced similar results. where those who received heroin use of drugs of 68% compared to only 48% for those who were taking methadone. And so again, the numbers don't lie with respect to the strong advocacy of these programs. But one of the differences is that while in Switzerland, when the numbers came out that showed these positive results, they then rolled these programs across the entire country. Here in Canada at present, we still only have the entire country in which you can receive prescribed heroin. And so once again, we need to expand access to these programs. But when expanding access, I think we also need to think innovatively about how to ensure that that access is reliable. Because again, it's one of the things that we've learned with the experience of the pandemic in March, while pharmacies largely stayed open and while supervised consumption facilities were able to stay open, clinics had to shut down. So what do you do in situations like this? How are we able to get some experimentation with various strategies, like for example, home delivery of substitutes such as methadone? So a question I have is can we do something similar with heroin, for example? In a facility in downtown, much like an ATM, in which you enter in a key and a password and you can receive a dosage of an opioid substitute such as methadone. And so again, is there something that we could do similarly with heroin in a controlled setting? In other countries around the world, these opioid substitutes are widely available in pharmacies. Can we do the same thing with respect to heroin? It would result in unsupervised consumption of these substances. But again, learning from examples around the world and looking at what's been done around the world, what we see is that there are other places that have had long-standing policies with respect to heroin prescription. And once again, Britain is an example of a country. When they initially passed their first law prohibiting heroin, about 6 years later, a committee by the name of the Ralston Committee concluded in their commitment that doctors should be allowed and able to prescribe heroin to certain patients on an ongoing permanent basis. And so this became a system, it became known as the British system, that operated for 40 years and continues to operate to a certain extent there as well. And so there's lessons to learn there, money and investment and political will, which unfortunately, when we've only got 2 heroin-assisted therapy clinics and 39 supervised consumption, it's clear that more needs to be done. And I think that a lot of this comes down to a question of political will. And anything else, if there was anything else going on that was causing tens of thousands of individuals to accidentally die, like what we're seeing with the opioid, funneling money into these initiatives and rolling out and expanding these initiatives as much as possible. But we're talking about illegal substances like heroin, drug century, have been involved in a war on drugs, and so the stigma and the labeling associated with them, I think, are a hindrance. And so decriminalization and the importance, I think, and I think one of the things that led to the success in Portugal with the numbers going down is the fact that decriminalization helped accelerate a process of changing attitudes around. There's lessons that we can learn there and bring here. And I'm not necessarily advocating for doing decriminalization exactly the same way as it's been done in Portugal. One of the things they require is that if somebody is found in possession of drugs, is that they have to appear before a committee of individuals that might require. We do have the bill on the floor. It's the private members bill currently. So it's not likely going to pass Parliament, but Erskine Smith. But what he's proposing is that we remove legislation prohibiting possession of all drugs completely out of the Controlled Drugs and Substances Act. The question I asked though is can we go one step further? A program in the United States known as LEAD allows for the purposes of possession, but even for selling drugs, if it's selling drugs on a small scale, which we know from research is most likely being done to help support family and help support themselves. So can we take this bill and can we move it one step further? And so in conclusion, that once again, he's looking abroad, he's looking to lessons from other countries. He says that what we find around the world is that with decriminalization, access to treatment increases, that we can learn there, but also a question that I'm happy to hear people say, and that is if you look closely at the legislation that he's proposing, it's asking to take the criminalization of drug possession completely out of the control, but it's not being replaced with any other scheme. In other words, it's not being reclassified as an administrative offense, for example. And so I wonder if that's the case, are we really talking about decriminalization, or are we perhaps talking about the legalization of drug possession with respect to tackling the opioid epidemic here in Canada? But thank you very much, and I'd love to hear your thoughts.
Fantastic, Stephen. Thank you so much. And I'm
Great,
sure
thank you.
we will all have questions, especially to fill in some of the gaps of the tech issues that got in the way of us hearing everything as clearly as I know we would have liked. I would love to turn things over to those of you that have joined us. So if you've got a question, please feel free to put it in the chat, or just let us know in the chat that you have one, and we can unmute you and you can ask it yourself, whatever is most feasible for you.
There was that, so Jen Clark here with the library. There was that question earlier about reducing the stigma within neighborhoods.
Absolutely. I'm just going to go back and see if I can find the question. How do we overcome the stigma within neighborhoods? And I think that's a great question. I think that there's a number of ways in which that I think there's a number of ways in which it can be done, but I think that the lesson that we learned from Portugal is that perhaps one of the most effective ways to accelerate that reduction in stigma is through decriminalization. The decriminalization of possession of drugs, and perhaps even decriminalization of possession, whether it's for personal consumption or for sale, that what we've learned from other countries is that with that decriminalization comes a changing in the way in which drugs is framed, the way in which it is socially constructed, because you're taking the criminal label away. You're decriminalizing, and so by doing that, reconstructing it from what is what is seen predominantly as a crime-related problem to a public health problem. And so I think that it's reducing the stigma, increasing awareness. There's a lot that's not known about substances and substance dependence factors that are related to it. And so I think in campaigns, and we've seen how public awareness has been used in the past, but it's often used in a way that's largely rooted in fear, creating fear around these illicit substances, fear around those who sell them, misinformation and information that's not entirely factual. And so I think that we need to use similar channels or similar mechanisms, whether it's public education, television, school, to reframe and send and send a more accurate and more realistic and holistic perspective to or account of the reality of dependence and the use of illicit historical, and puts it into a larger context. So I see a question here. Is it okay if I go to the next question, or? All right, so how large of a difference is the rate of opioid overdose in places like the United Kingdom compared to places like Canada? And could this be a reason for why there are not as many supervised consumption facilities? So that's it. And the rate of I don't have the exact numbers. What we do know is that the rate is considerably higher here in Canada, in North America in general, Canada and the United States, considerably higher here than it is in the United Kingdom. Portugal, high numbers at the end of the 1990s, heading into the early 20th century. But then, as you saw with that graph, that the number goes down very rapidly within 2 or 3 years after decriminalization. So there are variations, there are differences around the world for a number of reasons. It could help to explain why compared to here, and it's interesting because the United Kingdom has such a history in terms of being a trailblazer with things like syringe exchange programs, which I mentioned, or heroin prescription. But with supervised consumption facilities, it's the opposite. Here in Canada, we've established and opened quite a few more than in the UK, and it's taken a little bit longer. In the United Kingdom, and so certainly those kind of factors can can help, but at the end of the day, it's quite often sort of the perception of what the rates are rather than the reality. So the numbers are, although they are lower, they don't necessarily fully explain why, for example, in the early 2000s, when there was more of a similarity in rates of overdose, why we started moving towards establishing supervised consumption facilities, and they didn't. So and Carol's asked, are there trends with different groups or cultures? Do you know? This is one of the things where the best available evidence in the States as well as here in Canada, although we need to collect more. And one of the things is that we do need to collect more data and learn more in the Canadian context. Is that rates are relatively equal across groups, across we certainly see differences in from province to province, region to region. Those who are disadvantaged, there can be different, but across the range, this is a problem that affects and impacts everybody, regardless of culture or race or ethnicity. And important things that so often part of the stigma associated with the use of these substances, and what has led to the criminalization of so many of these substances, is a perception that they're associated with particular groups, and particular often racialized individuals, racialized groups, those who are being targeted, and those who are being perceived as threat. The criminalization of these different drugs take place. It's not because of concerns about the harms associated with these drugs, but rather who it is that's being perceived as using these drugs. So crack cocaine, for example, with those within the African American community in the 1980s, and other groups. But in terms of objective data, the problem is one that affects all individuals and all groups, unfortunately.
Stephen, it's Jennifer from the library.
Yes.
Do you know?
Yes, yes.
So Toronto being a very, very large urban area, does Toronto have a supervised consumption site? I know a couple years ago, Oshawa, there was a bid from Lakeridge Health and I believe Pinewood at the time, as well as some other supporting organizations that put in a bid for a supervised consumption site for this area. So if people are struggling and they are looking for a supervised consumption site, you commented that there's only 39 in Canada in total. So
That's
where
Yeah.
do people go?
That's a good question. I people go, so to answer your question, yeah, there are, and I can't I can't recall offhand how many are in Toronto at the moment, but there are a number of facilities, and some of them are run by the federal government, and so they're supervised consumption facilities. Some were funded by the provincial government. They work a little bit differently and have different procedures behind them, but there are a number of facilities in Toronto. So there's one, for example, relatively close to the Yonge and Dundas area, but there's also one in the west part of King Street. But the number is still about 6 or 7 for a city the size of Toronto that are far. They where do they go? They have to go to the nearest facility, which might not be close. And for many outside of Toronto, if we're talking about Oshawa, for example, in particular, then in most cases the reality is the option is that there isn't necessarily a place to go. For some, being able to travel into Toronto might be a possibility, but for many that's extremely difficult. So where do you go if a supervised consumption facility is part of the problem? In many of these cases, individuals then they might use with, or they might consume with others, but in a lot of instances, individuals they're in these substances by themselves alone, and it could be in places where because they're worried about the stigma and possibility of arrest, it's going to be in places like parks, alleyways, public washrooms, facilities where if somebody accidentally overdoses, the possibility of somebody being close by and able to intervene quickly, to be able to revive them using naloxone, for example, which is somebody. If someone can get to you quickly, then there's good chances that somebody can be revived and they'll be fine. But if they can't get to somebody quickly enough, then that's when these overdoses often turn into fatalities. So it really varies from person to person, and sometimes we hear about places that are not sanctioned or are unofficial, that people can go to, but it'd be risk, especially if there is concern that the police officers are going to be close by. And so in so many of these circumstances, if a consumption facility is not nearby, if it's not available, then people will often use alone, and will use in places that where somebody isn't going to find it. And that's the concern, and that's why these facilities, which we know are effective, and we know people say that's why more facilities need to be available. But again, it needs to be tied with a decriminalization that can help shift attitudes around the use of drugs, because that can help facilities as well. More people, let's say Oshawa does open a supervised consumption facility, more people will be willing to go to these facilities, and there will be more interest and will on the level of the government to fund and establish more of these. I think if there's a shift in these attitudes and reduction of that stigma through something like decriminalization. But does that answer your question?
It does. There's another question from Carol, who
Yes.
supervised the center as a nurse.
Yeah, normally a nurse. Sorry to interrupt, but yeah, absolutely. Normally a nurse. In some cases, the majority of situations, it's a nurse, but someone with medical experience, someone who is experienced and knows how to intervene quickly, and has access, has naloxone, and can use naloxone quickly to revive somebody, and that's what makes these facilities so incredibly effective for individuals who are on site, is that there's somebody there who is watching at all times. Within seconds of somebody experiencing an overdose, they can intervene and do all the right steps. But yes, it would be a nurse or someone with medical experience.
Stephen, hi.
Yes.
I was wondering if you could say a bit more about some of the obstacles or challenges to dealing with these issues in more rural centers compared to urban centers.
Mm-hmm. That's a good question. In more rural centers, I think part of the issue is a perception that's often that is quite often not true, that these are areas that don't require supervised consumption facilities. So a notion, and we see this in rural centers. We also see this in certain regions or areas across Canada too, like the Atlantic regions, where there's a perception that that this is not a problem experienced in these areas. That this is something that happens in urban centers, in larger cities like Toronto or Vancouver, not in rural areas. And so that can often be an obstacle. One of the reasons why Toronto, why there was so much opposition in Toronto for years, was this perception that the use of opiates wasn't a problem, and that changed. So I think that's part of it. Is in rural areas, this a sense that that this is that while people are certainly while there's certainly people struggling, that when it comes to opioid overdose deaths, that's not something that's happening. So I think that's one of the obstacles. One of the obstacles, certainly. Sometimes not as much familiarity with these facilities, but in general, what we also often see is that in terms of opposition to or obstacles to establishing these facilities, there's certain groups that really help, or that can really help facilitate getting, say, for example, a city council, for example, or a town council, or city, include things like hearing from support from police officers. So if you have a police chief who's supportive, then that can go a big step of the way. If you have support from people around a government table, that can help too. But quite often, communities in these areas, they often need to be convinced that a large number of people in these communities will support these facilities. And so sometimes one of the obstacles is just not having any data, or not knowing to what extent there is support. And so surveys need to be carried out. Often one of the key steps moving towards the establishment of a facility is carrying out a public opinion survey. And when a survey comes back and you then find out that, you know what, the vast majority of people support, and most of the time that's what we see. When a survey is carried out, before the surveys are carried out, there's often assumptions that you know, there's going to be mostly opposition. Most people aren't going to like this idea. This would be politically unsafe if you're a politician voting on something. But most of the time what we find is that when surveys are carried out, you know, good rigorous surveys and focus group meetings within these communities, that that the majority of people are on side. And so when leaders in these areas know that the majority of people in these communities are on side, then they're more comfortable moving to back these. And so I think that's an obstacle, perhaps in particular, is that we don't have a lot of data, particularly in rural areas, and we need to reach out. This kind of outreach and soliciting of feedback and information needs to be carried out. Does that answer your question? Yeah.
It does, absolutely. Okay. And thank you so much. I wanted to take advantage of this summation of yours to thank you again for joining us, Stephen. And thank you to our guests for your fantastic questions that help us get into this issue in more detail. Jen, I believe the Oshawa Public Library will have some resources up for people to follow through if they want more information, to learn more about these kinds of things. Yes?
Yes, absolutely. If you like, I can take just about a minute here and share my screen with you. So here we have some items that are available now at the Oshawa Public Library. Overdose is an astonishing and powerful look at the ongoing opioid crisis, the only book of its kind in Canada. Perrin is a law and policy expert in Vancouver and challenges many assumptions about the people who use opioids. Why do people use fentanyl? Where does it come from? And why can't we stop it? Overcoming Opioid Addiction is an evidence-based guide for people who live with the addiction and can also be used by those who work with or are friends of addicts. It also goes into detail regarding the uniqueness of opioid addiction and why it is more difficult to treat than other forms of substance abuse. From his perspective as an addiction physician working on the front lines of the epidemic, Dr. Raman discusses the disease and the cure in the age of fentanyl. It brings the hopeful message that a coalition of patients, advocates, scientists, doctors, and nurses are finding solutions and making plans to stem the overdose deaths, block the spread of fentanyl, and end the epidemic. Dope Sick is journalist Beth Macy's chronicle of the epidemic in the United States. It traces how the crisis began in the 90s and explores how that microcosm of addiction ballooned into something much more dangerous and wide-sweeping. Dope Sick was also made into a TV series slated to be released next year on Hulu, I believe. If you prefer to watch instead of read, then I recommend Opioids, Inc. and Understanding the Opioid Epidemic. They're both PBS documentaries that examine how the epidemic began, continues to exist, and the role that the drug companies play in it. Time Bomb is a CBC doc from the Fifth Estate that explores the devastating effects of being addicted to OxyContin, the opioid that started it all. For all these and more, I believe Stephen might be sharing some resources with us as well after. Then you just need to visit our website. Yeah, just visit oshlib.ca. Thank you.
Fantastic.
Great, those look fantastic.
And before we wrap up for the evening, I would like to thank you all again, and I would like to slightly selfishly remind you of our next installment in 2 weeks on December 14th. And it is slightly selfish because I will be making the change from host to speaker. So if you are interested in learning more about Hallmark movies, just in time for the Hallmark holidays, I'll be talking about Hallmark films and the role they play in Canada's film industry. So thank you again, everyone, so much for joining us. It was wonderful to have you, and we look forward to you joining us again soon.
Bye, thank you.
Great, thank you very much again. Take care.
Good night, everybody. Thank you so much.
Great
Thank you,
timing on your upcoming talk.
Good night.
Good night, everybody.